¿Alguien sabe de qué se trata esto? Adolfo visitó a René y Adolfo le preguntó a René, ¿usted cómo hace para mantener en orden al cuerpo médico? Y le regaló esto. Los llama al orden con esto, vienen ahora René Blanding, vicepresidente de Asuntos Médicos de Johns Hopkins Bayview Medical Center. Ella desde 1992 ha sido anestesióloga en Hopkins Bayview. Se desempeñó como directora médica de cirugía del centro médico durante 7 años y fue nombrada vicepresidente de Asuntos Médicos en julio del 2011. Dentro de su formación, de su background, están sus estudios en biología en la Universidad de Carolina del Sur. Es médica de la Escuela de Medicina de la Universidad de la Florida. Tiene un máster en salud pública de la Universidad de Carolina del Sur y realizó su residencia en Louisiana State University. Renee va a estar acompañada de Eter Hoang. Eter es bioquímico, médico de la Universidad de Kansas, gerente de la Unidad de Inteligencia de Negocios de Johns Hopkins Bayview Medical Center y es consultor en diferentes áreas de análisis de datos. Es experto en Lean Six Sigma y adicionalmente tiene una maestría en Administración de Salud de la Universidad de Minnesota. Traté de traducir la conferencia y creo que harnessing es una palabra imposible, pero básicamente uno podría decir que la conferencia que nos van a dar es aprovechamiento de la analítica para mejorar prácticas clínicas y operacionales. Le ruego a René y a Eter que nos acompañen en este momento. René, come here. Me está gustando esto. Creo que se lo va a quitar a Adolfo.
Buenos días. I will tell you before moving forward, I am quite sobered by the story that we saw and heard before. Whether you speak Spanish or you speak English, it has impressed my heart and I will not forget. So thank you for sharing that story with all of us so that we can get better and we can do better. So thank you. So on yesterday, I said that I could not speak Spanish, and that was my one regret for here. So I noticed that the talk we have been speaking a lot about risk and quality and continuous improvement. So I thought I would take a risk before starting and say a few words in Spanish. My quality is not very good, but it is part of my continuous improvement. Gracias por tu hospitalidad. Espero verte de nuevo. Adiós y gracias, amigos. So I thought we would start our talk today talking about harnessing analytics to improve clinical and operational practices. The objectives of our talk today are to talk about our organization's journey in adopting business intelligence and data analytics to drive clinical and operational change. We want to discuss some of the results that are based on those initiatives And we also, we wanted to provide a live demo, but we recognized that because of some of the, I think the speed of the broadband, we won't be able to, but we will be happy to do that offline. So in terms of the global need, why do we need analytics? Of course, it drives future strategies. It is there to improve clinical outcomes. We want to enrich patient-centered care because that is really why we are here. In all of the analytics, in all of everything that we do, we want answers so that we can provide better care for our patients. We need it. And that's one of the reasons that we ask for it. We want to improve operational inefficiencies, and we want to reduce cost. And the graph that you can see shows that, to be honest with you, many of the high-performing institutions want to guide future strategies by using analytics. This graph, in terms of what you can see here, is that the real reason that people, in terms of strategizing to use data analytics, is that they want to have strategies to determine population health outcomes. They want to actually improve quality initiatives. And they also basically have other issues in terms of needs, but you can see here what the reasons are. In terms of a data-driven decision-making strategy, we at many times are subjective. We talk about personal opinions, we talk about assumptions, interpretations. Sometimes we're having coffee and we talk about some of these things, and they're commonly rooted in personal feelings. We would like to move from the subjectivo to the objectivo and have observations of measurable facts. We want to use facts, figures, and data to basically drive a lot of the things that we are doing. I love this graph, namely because on the y-axis it talks about your competitive edge. I also say your clinical edge. And the x-axis actually talks about the degree of intelligence. If you can see at the very, very bottom at the intersection of the y and x-axis, they're standard reports. It's what we do. And as you move further and further up to the right, you can see that you become more intelligent in terms of your business intelligence. You actually have forecasting, you actually have predictive analytics, and ultimately you have prescriptive analytics. Why is that important? It's important because you can create clinical pathways based on those predictive analytics. Perhaps we can use some of the vital signs when patients come in to create individualized clinical pathways and take care of our patients in a more targeted way. That's where we need to move, to where we are literally prescripting the clinical care of our patients on an individualized basis. Sometimes I wonder, in terms of our intelligence, when we're sitting at dinner and we can check what the scores of the soccer game are, or we can check basketball, how come we can't do that for our patients? How come we can't have that same beat-to-beat understanding of what our patients are going through? And that is where I think we need to go. In terms of missing some of the symptoms and signs, I think the further we move toward the right in terms of our intelligence, the better we will be in terms of our clinical edge. Again, a lot of just reactive work that we do when we get data, we react to it. I call it looking in the retrospectoscope or the rearview mirror. We look at what we did yesterday, we look at what we did last month, we look at what we did last quarter, and that data actually, the trail of that decision making has gone cold. As you want to move closer to the right, again, you want to become prescriptive. You want to have your patients in an individualized clinical pathway. Sometimes I think that when we put patients in when we admit patients and we give them a standard vital signs every shift, or we do certain things in a very, very standard way, we're missing some of the pathways that our patients actually need. Sometimes patients need vital signs more than one per shift. Sometimes our patients need better clinical pathways so that we actually can take better care of them. We can only have that if we have the clinical data to support that. In terms of our struggle, as we try to get this data and try to take care of our patients in a better way, we see that the large majority, 79% of our time is spent gathering this data. And what do? It leaves much less time for us to interpret and to react to it. That's where I think we as medical and clinical professionals have to get better because we recognize that at this particular time, sometimes that extraction is manual. I know that based on my experiences, I am the medical director for the operating room. We have a tremendous amount of continuous variable data, and I always, at the very beginning, had to go to the record and write it down in a spreadsheet. And that changed when I met Eter, and we'll talk a little bit about our journey. So we want to reverse this. The computer is actually driving a lot of what we're doing. We want to have the human being actually overcome that computer and actually command that computer. Namely because I think that that would help with a lot of the manual extraction, that will help with a lot of the arduous things that we do. There has to be an intersection between the clinical and operational goals, though. We want, again, treat our patients more effectively. That is our reason to be. That is why we are here. But we also recognize that there are some efficiencies that can be gained by looking at the operational aspects. I can tell you, though, that much of our data focus has been focused on administrative data up to this point and operational data. Our goal is to shift that toward patient care. I'll tell you a little bit about our journey, and then I'm going to hand over to Eter. I told you that much of my extraction and use of the data was manual. I toiled greatly trying to create decision-making and operational decisions as well. And I met Eter. He was an administrative resident about 4 years ago, and he came into my office as a meet and greet. He told me some of the things that he was able to do, and I said, let's tackle this together. And so you can see that since 2014, we have created we've been very, very impressive in what we've done. Why did we do it? We did it, if you look at the right side, the gray side, always focused on our patients. In terms of the chronic obstructive pulmonary disease, we did it to reduce readmissions and length of stay in our chronic patients. In terms of our perioperative application, we wanted to optimize the care of our patients going through our operating room. We also had some supply chain management issues. That's where the operational piece. That perioperative application is probably the most successful one in the entire health system. It's used widely by 5 of the 6 hospitals. More than 400 users actually use it on a daily basis. When it is not working properly, they make their way to Eter very quickly to find out what's going on. We did open encounters, again, to reduce delays in treatment. So when our patients, we're on Epic, and when a physician does not close that encounter, the next physician cannot see the care that has been rendered. And so we recognized that there were a high amount of encounters that were not closed. And so, again, hearing that anecdotal data, we took it and we turned it into something very, very objective. So you, as a physician, if I had written a note and had not closed it, I know who is not closing their encounters now. I actually reach out to those physicians, I reach out to their chairs, they close those encounters so that pathway, that clinical care can move forward to the next stage. In terms of our antibiotic stewardship, utilization of the antibiotics, very, very important. As always, again, performance evaluation for our physicians. We developed an application for that. Consults. We heard a little bit of information about that, and Eter will talk a little bit. Again, there's a common thread in how we use our in terms of the what goes in my mind, tiempo de consulta. We saw that on there, and I think that that's a common thread almost worldwide. So we'll talk a little bit more about that. Eter, are you ready? All righty.
Buenos días. I feel honored and feel privileged to be here amongst all the great minds that have come together to tackle the challenge of improving health and quality. I've been humbled just by all the great thoughts and ideas that I've learned from this conference. This is an example. We spoke on Wednesday. We gathered data from over 170 participants in the crowd. We did a word cloud to understand what are some of the barriers to patient-centered care. And Fortunately for us, one of the names is tiempo de consulta, the time of consultation. And it worked really well with today's presentation, since it is a challenge for us as well that to be able to deliver proper care, we are looking at multi-specialty collaboration in order to diagnose a patient properly. And we recognize that it is a challenge many times for a consultation to be completed in a timely manner. And so I'd like to show a little bit about why we worked on the consultation process. We found that the turnaround time was over 10 hours to complete a consultation. When you see a figure on the bottom left of 70.7%, in our minds we think that doesn't sound bad to complete a consultation within 24 hours. But that also means that 30% of the time the consultation took longer than 24 hours. To us, that is unacceptable, that we must be able to provide timely care and consultation so that the patient can have the best chance at quality care. And so as we looked at the data, I show you some of the dashboard here. We started looking at variations in our day-to-day practice. In the past, to get consultation data, we would request a report that would come every quarter, every month, every 6 months. By the time we get that data, it is too late to react to. And so we went on a journey to see if we can pull the data in real time or near real time. This allows us to be able to identify bottlenecks in our consultation process that is updated on a daily basis. I wanted to also show this. I don't expect anyone to be able to see and read, but what I'm hoping to be able to illustrate is that the consultation process is not simple. That if you look on the left-hand side over here, these are the ordering departments, and these are all of the departments that are consulting with the ordering departments. It is a highly complex process that requires engineering and coordination. Even the emergency department alone, you can see that there are certain areas that they'll consult more to than others, but nonetheless, it is extremely complex in terms of how many different groups a physician in the emergency department will consult in order to provide the best care. This is an ongoing project for us. As we built the dashboard, we started realizing that the metrics that we started off with were not sufficient in being able to truly understand the root cause to why we were delaying our consultations. And so the next step for us will be to understand the turnaround times by the different departments, by the specific physicians, that we would be working with the different specialties to understand their individual challenges. Data will only get you so far if you are isolated in a room and building these figures. We must be on the floors, we must be working with the clinicians, we must be working with all the different disciplinaries to understand the delays. And so we've learned that an analytic project cannot simply be a data project, but that it is a multidisciplinary project. I wanted to also share a little bit about the open encounters. This is something that Dr. Blanding mentioned earlier, that when a physician isn't able to sign and close their encounter, we have delays in being able to share that same encounter. And from a financial perspective, we cannot bill for an encounter unless it is closed and signed. And so we recognized this was a 1% problem for us, but this 1% problem for us represented a $1.75 million cash stream issue, as well as a significant delay in being able to see a patient's record. We were finding that with these open encounters, had we not done anything, you'll see here, this is the general trend of where we were going with our encounters. They were continually being opened and not closed. And as a patient, or as a physician continues to add more visits, it would only compound to the open encounters that they had. And so we decided at this point that we needed to intervene. Otherwise, we made projection models that said that if we did not intervene, we would be at a 280% variance. And so what we did was, over here at this point, was the starting point of when we started building our application. And we presented our Open Encounters application during this time to our medical directors. And initially, you see a decline in the behavior, in the characteristics of closing the encounters. Then over the next several months, it started going back up again. And we recognized that simply showing the providers the data was not enough to change behavior, that we needed more. And so Dr. Blanding helped instate a suspension policy that allowed behavior to be enforced with accountability and some kind of policy to help the physicians. And so then you see a drop in our open encounters to a more acceptable rate of turnover. What you end up seeing is a 44% reduction in 4 months after the policy had been created. And not only was it policy, but we had a navigator to help work with physicians one-on-one to understand their challenges of what was keeping them from closing the encounter. And we paired that with, and this is an example of our dashboard, we paired it with these kind of graphs here, where we started identifying whether certain encounters were open longer than the others. If a physician had 300 encounters open, and they only had so much time to close them, how do we prioritize which ones to close first? It's not simply about focusing on the department that has the most encounters, but more focusing on the encounters that have the most old encounters. And this allowed us to be able to prioritize what should we tackle first. We also put physicians, comparing them to each other. I've kind of blotted out their names, but you can see which physicians are challenged with being able to close their encounters. Now we know that physicians are trying to do the right thing, that with the onset of electronic medical record, there's a lot more documentation that needs to occur. And so we didn't want to just simply push data to the physicians, but we wanted to see how can we partner and help them do their job more efficiently so that they could spend more time with the patients. And so we didn't simply do this project to see and keep the physicians accountable. We started pulling data on what is their lifestyle and what is their work-life balance as well, and what may be contributing to some of these delays. And we found, this is an example of one of our physicians here, they spent the majority of their Saturday and Sundays on the weekends closing these encounters, typing up their notes, and reviewing them. And you can see that they were closing these encounters all throughout the evening and even some mornings as well too. And so you think about this and we talk about the quadruple aim and we try to understand how is the caregiver's experience. This does not look like a very good experience. This could be time used to spend with family, to relax, enjoy, but these physicians not only are taking care of patients during the week, but they are spending their time with documentation in the evening, or in the evenings and in the weekends. And so we started humanizing the process so that data is not simply something to use against us, but for us and with us. And so this was an area of eye-opening for us that we needed to do more for our physicians to help them be successful. We were going to do a demo of the dashboard, a live demo. Unfortunately, we may have to, due to connection issues, we have slide shots of that instead. And so, I think they actually got hidden. But we have a perioperative dashboard that we'd be happy to share afterwards if anybody is interested in. It's one of our most successful applications. A lot of physicians, administrators all use it. It's mainly an operational dashboard. What we were identifying was that with the complexity of the operating room, we had to monitor things like operating room delays, volume, case lengths, understanding if we're scheduling our cases correctly. And what we ended up finding was that there was a significant variation even amongst our how we collect data and how we disseminate it, namely in operational flow and in supply chain management. With our dashboards, we're able to, in real time, drill down, not just comparing our 5 different hospitals. We had an example showing that within the 5 hospitals, for a knee replacement surgery, on average the cost is about $5,000. And most people will report a single number as 5,000. But when you start comparing them with other hospitals, we realized that there's a large variation. Some hospitals average was 10,000, 12,000, and others were down to 2,000. But then we wanted to focus just on our own hospital, and we looked at all the physicians that were doing knee replacement surgeries, and we were finding that even comparing within our own physicians, that there was up to a 28% variation between physician 1 and physician 2. Some physicians were doing knee replacements at 4,000, and some were doing it at 6,000. And we identified that this is an area of opportunity for us to standardize so that we can improve the cost of care as well. This slide here is very indicative of one of the additional benefits of building these dashboards. Not only do they, as Dr. Blanding showed earlier, we spend 79% of our time, or 79% of our analytics staff spend more than 50% of their time just simply gathering data and not enough time analyzing the data to understand improvement opportunities. And so what this graph shows you here, this is from our EPIC reporting system, and it shows the people that have placed requests for data and for analysis. You'll see that for all the other modalities, there are peaks in multiple areas. For the operation, or for the perioperative department, after we built the dashboard, and right here, you'll see that it is almost non-existent that people are requesting data, that they can use the application in real time to gather data when they need it the most, as opposed to waiting for someone to build them a report. I wanted to end with this slide here. This is part of our population health focus in tackling with our opioid crisis. This is a map of the Baltimore region that identifies the overdose patients that are coming in, and we're giving them naloxone to treat their opioid addiction. And what we're seeing here is that we're using data now to empower us on how, with the minimal resources that we have to work with the community, how do we best utilize those resources? As you can see here, Bayview Hospital is here, and our flagship hospital, Johns Hopkins Hospital, is here. Patients are scattered all around here in these large clusters. Now, we recognize that healthcare is not simply within the four walls of our hospital, that we must be able to reach out to the communities and partner with the communities to be able to tackle some of the issues that we are faced with. Mental health and drug addictions are a large part of our readmission population, and it's a population that is struggling. And so utilizing analytics to be able to identify where can our resources be used best and how, we started identifying, in the yellow you'll see are all the different churches that are where our patients are at. And we are also in the 44, the pink, that represents the 44 churches that we have partnerships with that help us with distributing naloxone kits, with helping with education on drug prevention. And so we would like to continue to use data like this in order for us to identify strategies in order to tackle a lot of the problems that we have in the hospital and beyond the four walls. And so when we look at examples like this, we start thinking about what does patient-centered care look like? Patient-centered care is not simply a concept, not simply a strategy, but it has to be part of our culture and part of our way of life, part of the dissemination down to every single discipline, from the physicians to the nurses down to the EVS, that we must use data to not only drive some of our initiatives, but that they would help us be able to stay accountable and identify opportunities for strategic improvements. So I wanted to end with some of the challenges that we faced as we started this journey in integrating data analytics into our clinical and operational focuses. That access to data was part of the challenge. We saw in consultation earlier, one of the reasons why it is still an ongoing process is that we currently capture portions of the data. We can tell when a consult is complete, and we can tell when a consult note is started, but we actually cannot measure currently when a consult officially begins. And so part of that driving process is understanding what data do we have access to and how do we get the data that we need to solve our questions. Resource investments, I think if we had a choice between hiring a physician analyst, we would typically go with the clinical route since that is our mission. And so being able to identify resources to be able to either train more of our clinical staff to do more analysis, as well as enabling additional staff within the hospital, and building up data resources that can pull the data and disseminate it quickly. Acceptance, I think Felipe had brought that up earlier in terms of can people trust the data? And so in all of our projects, they're multidisciplinary. We work with the physicians so that they help with the validation, they help with the metric definitions so that they can trust something that they built and were a part of. Data literacy is a big thing. Since most analysts are used to pulling data and not enough time analyzing the data, we are finding there's a gap between how to actually interpret the data and use the data. And then at the end of the day, there's reactivity to the data. If you see a low score or a challenge to some of the trends, can we react quick enough to do something about it? Right now, we have 70% of our consults completed in 24 hours, but do we have the resources to be able to react to that data so that our percentage can go up to 100%? And so there are a lot of opportunities that I'll go ahead and give this back to Dr. Blanding. But I appreciate your time, and it's an honor to speak.
So I just want to say that these numbers are not just numbers. These numbers are our patients. And we have to use these numbers to better our care. And I know that I, as a physician, oftentimes bristle when we talk about the money aspect. And I've also seen that on this journey, we often bristle at the data aspect. We have to join this revolution. We have to embrace it. We have to use it to use clinical care to take care of our patients on a daily basis. One of the things that Eter mentioned earlier, or we may have omitted, is that the dashboards are actually in real time, essentially real time. The perioperative application is as current as yesterday. All of these applications are current. You can use these to drive change on a daily basis. So I thank you for your attention. I wish you well, and I certainly thank you for this privilege. And I just ask that in the future, we continue to use this to take better care of our patients. Thank you so much.